Question 1. A 68-year-old male presents to the outpatient clinic with chronic severe low back pain, radiculopathy, and numbness extending down his left leg. Imaging reveals lumbar spinal stenosis with neurogenic claudication. The physician documents lumbar stenosis with left L5 radiculopathy due to disc degeneration. Which of the following is the most appropriate ICD-10-CM code assignment? A. M48.061, G55.1. B. M48.06, G54.1. C. M48.06, G55.1. D. M48.06, G54.1, G89.29. Answer: B. M48.06, G54.1. This question assesses the proper sequencing and specificity of ICD-10-CM codes for spinal conditions. The key is to identify the primary diagnosis, which is lumbar spinal stenosis, M48.06, and then code the associated radiculopathy, G54.1, specifically mentioning L5 radiculopathy. Since lumbar spinal stenosis is an inherent cause of neurogenic claudication and radiculopathy, and the documentation specifies disc degeneration as the underlying cause, we code the specific radiculopathy rather than a generic nerve root compression. Always remember to code to the highest specificity and apply the guideline that if a condition is a manifestation of another, and there is a combination code, use it, or code both conditions in the correct sequence. Question 2. A patient undergoes an arthroscopic meniscectomy of the lateral meniscus in the right knee. During the same operative session, the surgeon also performs an arthroscopic chondroplasty of the patellofemoral joint in the same right knee. How should these procedures be coded using CPT? A. 29881RT, 29879-59RT. B. 29881RT, 29879-51RT. C. 29881RT only. D. 29880RT, 29879-59RT. Answer: A. 29881RT, 29879-59RT. This question tests your knowledge of CPT coding for arthroscopic knee procedures and the appropriate use of modifiers. The keyword is arthroscopic and same operative session for procedures on the same knee. An arthroscopic meniscectomy, 29881, and an arthroscopic chondroplasty, 29879, are distinct procedures. However, per NCCI edits, 29879 is bundled into 29,881 when performed in the same compartment unless performed in a different compartment or distinct area. In this scenario, the meniscectomy involves the lateral meniscus, while the chondroplasty is of the patellofemoral joint, which are considered distinct areas or compartments, thus allowing unbundling with modifier 59. Always check NCCI edits when coding multiple procedures performed during the same operative session on the same joint to ensure accurate reporting. Question 3. A 45-year-old female is admitted for a total abdominal hysterectomy with bilateral salpingo-oophorectomy due to endometrial carcinoma. During the procedure, the surgeon notes extensive adhesions requiring adhesiolysis, which significantly prolonged the operative time and increased the complexity. What is the correct ICD-10-PCS code for the principal procedure? A. 0UL70ZZ. B. 0UL70ZZ, 0UN70ZZ. C. 0UT90ZZ. D. 0UT90ZZ, 0DN90ZZ. Answer: C. 0UT90ZZ. This question assesses the correct ICD-10-PCS coding for a total abdominal hysterectomy with bilateral salpingo-oophorectomy. The key elements are total abdominal hysterectomy and bilateral salpingo-oophorectomy, both performed via open approach. In ICD-10-PCS, A hysterectomy that also includes removal of the fallopian tubes and ovaries is coded using the root operation excision or resection for the uterus, with the body part value encompassing the tubes and ovaries when removed with the uterus. Specifically, a total hysterectomy including bilateral salpingo-oophorectomy is coded as excision of uterus, total, with all supporting structures, using the specific body part value for uterus, total, and bilateral adnexa. The adhesiolysis is considered an integral part of the main procedure and is not separately coded unless it is extensive and documented as such, or if performed in a distinct site for a distinct reason, which is not indicated here as it simply complicated the primary surgery. Remember, PCS coding focuses on the objective of the procedure, and integral components are typically not coded separately. Question 4. A 72-year-old patient with a history of COPD is admitted to the hospital with acute exacerbation of chronic obstructive pulmonary disease and acute respiratory failure. The physician documented acute respiratory failure due to COPD exacerbation. What is the correct sequencing for the principal diagnosis? A. J44.1, J96.00. B. J96.00, J44.1. C. J44.9, J96.00. D. J96.9, J44.1. Answer: B. J96.00, J44.1. This question tests the correct sequencing of diagnoses in ICD-10-CM when two conditions are present and one is stated to be due to the other. The crucial phrase is acute respiratory failure due to COPD exacerbation. According to ICD-10-CM sequencing guidelines, when respiratory failure is explicitly documented as being due to another acute condition, like an acute exacerbation of COPD, the acute respiratory failure is sequenced as the principal diagnosis. Therefore, acute respiratory failure, J96.00, is coded first, followed by the acute exacerbation of chronic obstructive pulmonary disease, J44.1. Always remember to follow the due to guideline when present, which typically places the manifestation or complication as the principal diagnosis if it's the reason for the encounter or admission. Question 5. A patient presents for a preoperative evaluation for hip replacement surgery. The surgeon performs a comprehensive history and physical examination, decides the patient is a good candidate, and discusses the risks and benefits of the surgery. No significant new problems are identified, and the physician's medical decision-making is of low complexity. What is the correct CPTE/M code for this service? A. 99,203. B. 99,213. C. 99,202. D. 99,214. Answer: C. 99202. This question assesses the appropriate CPTE/M coding for a new patient preoperative evaluation based on medical decision-making, MDM, complexity. The scenario states comprehensive history and physical examination, which typically points to a higher level. However, for E/M coding since 2021, the code selection for office or other outpatient E/M services, 99,202 to 99,215, is primarily based on the level of medical decision-making, MDM, or total time spent. The key phrase, medical decision-making is of low complexity, is the determining factor. Even with a comprehensive history and exam, if MDM is low, the appropriate code for a new patient is 99202. Always prioritize the documented MDM or total time for outpatient E/M services. Question 6. A patient is admitted to the hospital for elective removal of an indwelling kidney transplant catheter due to infection. The catheter was placed at an outside facility. What is the correct principal diagnosis for this admission? A. T83.511A. B. T83.511D. C. N99.82. D. Z45.81. Answer: A. T83.511A. This question focuses on the appropriate principal diagnosis for an admission due to a complication of a surgical device. The crucial information is removal of an indwelling kidney transplant catheter due to infection, indicating a complication of a device. According to ICD-10-CM guidelines, when an admission is specifically for the management of a complication of a device or implant, the complication code is assigned as the principal diagnosis, followed by codes for any associated infection or other conditions. The ANT 83.511A signifies the initial encounter for this complication, meaning the patient is receiving active treatment for the infection of the catheter. Remember to identify if the encounter is for an initial treatment, subsequent care, or sequela when assigning external cause codes or complication codes. Question 7. A 5-year-old child presents to the emergency department after accidentally ingesting a large amount of an adult's blood pressure medication. The child is exhibiting symptoms of severe hypotension and bradycardia. The physician performs gastric lavage and administers activated charcoal. Which is the correct primary external cause code for this encounter? A. X44.XXXA. B. T46.5X1A. C. T50.991A. D. Y92.010. Answer: A. X44.XXXA. This question tests the correct application of external cause codes in ICD-10-CM for poisoning. The keyword is accidentally ingesting an adult's medication, leading to symptoms of severe hypotension and bradycardia, indicating a poisoning event. The primary external cause code describes the circumstances of the injury or poisoning, and for an accidental poisoning by an unspecified drug or biological substance, X44.XXXA is appropriate. The A suffix denotes the initial encounter for the poisoning. Codes like T46.5X1A describe the poisoning itself, e.g., poisoning by antihypertensive drugs, which would be the primary diagnosis, while Y92.010 would be a code for the place of occurrence, which is a secondary external cause code. It's vital to remember that external cause codes describe how the injury or poisoning happened, not the nature of the condition itself. Question 8. A patient is undergoing chemotherapy for metastatic colon cancer. During a routine follow-up, the oncologist notes the patient is experiencing severe, intractable nausea and vomiting as a side effect of the chemotherapy. The patient is admitted for aggressive hydration and antiemetics. What is the correct principal diagnosis for this inpatient admission? A. K92.9. B. R11.2. C. C18.9. D. T45.1X5A. Answer: D. T45.1X5A. This question assesses the correct principal diagnosis for an inpatient admission related to an adverse effect of a drug. The keywords are severe, intractable nausea and vomiting as a side effect of the chemotherapy and admitted for aggressive hydration and antiemetics. According to ICD-10-CM guidelines for adverse effects, if the admission is for treatment of an adverse effect of a drug, the adverse effect code, e.g., T45.1X5A for adverse effect of antineoplastic and immunosuppressive drugs, is sequenced as the principal diagnosis, followed by the nature of the adverse effect, R11.2 for nausea with vomiting. The cancer, C18.9, is a secondary diagnosis. Remember that adverse effect means a side effect correctly prescribed and administered, and when it is the reason for the admission, the T code for adverse effect is primary. Question 9. A surgeon performs a total hip arthroplasty using a cementless technique. During the same operative session, a bone graft is harvested from the iliac crest and used to augment the acetabular reconstruction. What is the correct CPT coding for this scenario? A. 27,130. B. 27130-20902. C. 27130-20900. D. 27130-20,902-51. Answer: A. 27130. This question evaluates the understanding of CPT coding for total hip arthroplasty and whether associated procedures are separately reportable. The key procedures are total hip arthroplasty, 27130, and bone graft harvested from the iliac crest used for acetabular reconstruction. According to CPT guidelines and NCCI edits, the harvest and placement of a bone graft, 20,902 or 20900, when performed through the same incision and used to facilitate the primary procedure, like a total hip arthroplasty, is considered an integral component of the major surgery and is not separately reported. This is a common bundling scenario. Always remember that many preparatory or facilitative procedures are considered inherent to the primary surgery and are not separately coded. Question 10. A patient presents to the emergency department with abdominal pain, fever, and leukocytosis. Imaging reveals acute appendicitis with localized peritonitis. The patient is taken to surgery for a laparoscopic appendectomy. What is the correct ICD-10-CM diagnosis code assignment? A. K35.80. B. K35.80, K65.0. C. K35.89. D. K35.89, K65.0. Answer: D. K35.89, K65.0. This question tests the specificity of ICD-10-CM coding for acute appendicitis. The critical information is acute appendicitis with localized peritonitis. According to the ICD-10-CM index, when appendicitis is documented with localized peritonitis, the combination code for acute appendicitis with generalized peritonitis, K35.80, is not appropriate. Instead, you code for other acute appendicitis, K35.89, and separately for the localized peritonitis, K65.0. This requires coding both the appendicitis and the peritonitis separately to achieve the highest level of specificity and correctly capture the patient's condition. Always be precise with terms like localized versus generalized when coding peritonitis associated with appendicitis. Question 11. A patient with end-stage renal disease, ESRD, on chronic hemodialysis is admitted with shortness of breath. Documentation states fluid overload due to ESRD, managed with adjustment of dialysis schedule. What is the correct principal diagnosis for this admission? A. N18.6. B. I50.9. C. I50.814. D. Z99.2. Answer: C. I50.814. This question assesses the correct principal diagnosis for a patient admitted for a complication of ESRD. The key phrase is fluid overload due to ESRD, managed with adjustment of dialysis schedule, indicating that the fluid overload is the reason for admission and directly related to the ESRD. According to ICD-10-CM guidelines, when a patient with ESRD is admitted for a complication, the complication code is sequenced as the principal diagnosis. Fluid overload in the context of ESRD specifically translates to a type of heart failure often described as end-stage renal disease with volume overload, which maps to I50.814, ESRD with volume overload. N18.6, ESRD, and Z99.2, dependence on renal dialysis, are secondary diagnoses. It is important to remember that the condition prompting the acute admission, especially if it's a complication of a chronic disease, is often the principal diagnosis. Question 12. A 30-year-old female undergoes a diagnostic colonoscopy. During the procedure, a 1.5 centimeters sessile polyp is identified in the descending colon and removed by snare polypectomy. What are the correct CPT codes for this encounter? A. 45,378. B. 45,385. C. For 5378, for 5385. D. 45,379. Answer, B. For 5385. This question tests the proper CPT coding for a colonoscopy with polyp removal. The critical information is diagnostic colonoscopy and sessile polyp, removed by snare polypectomy. When a polyp is removed during a diagnostic colonoscopy, only the therapeutic procedure, the removal, is coded, not the diagnostic colonoscopy itself. Code 45385 specifically describes a colonoscopy with removal of tumor, polyp, or other lesion by snare technique. Do not code 45378, diagnostic colonoscopy, separately, as it is considered an integral part of the more extensive therapeutic procedure. This is a common bundling principle. If a diagnostic service leads directly to a therapeutic service during the same encounter, only the therapeutic service is typically reported. Question 13. A patient is admitted for sepsis due to a Staphylococcus aureus infection of a central venous catheter. The physician documents sepsis secondary to catheter-related bloodstream infection, CRBSI. The patient has septic shock and multiple organ dysfunction syndrome, MODS. Which is the correct principal diagnosis? A. T80.211A. B. R65.20. C. R65.21. D. A41.01. Answer, C. R65.21. This question assesses the correct principal diagnosis for sepsis with septic shock and MODS related to a device. The key phrases are sepsis secondary to catheter-related bloodstream infection, CRBSI, and patient has septic shock and multiple organ dysfunction syndrome, MODS. According to ICD-10-CM guidelines, when a patient presents with sepsis and septic shock, the septic shock, R65.21, is always sequenced first, followed by the code for the underlying sepsis, A41.01 for Staphylococcus aureus sepsis, and then the code for the catheter infection, T80.211A. This guideline prioritizes septic shock as the principal diagnosis when present. Always remember the specific sequencing rule for sepsis with septic shock, where the shock component takes precedence. Question 14. A 62-year-old male with a history of hypertension presents for an annual wellness visit, AWV, with his primary care physician. During the visit, the patient mentions he has been experiencing new onset chest pain. The physician performs an expanded problem-focused examination related to the chest pain and orders an ECG. What CPT codes should be reported for this encounter? A. G0439. B. G0439, 99,213 to 25. C. G0438. D. G0438, 99,213 to 25. Answer, B. G0439, 99,213 to 25. This question evaluates the correct coding for an annual wellness visit, AWV, when a significant, separately identifiable problem is addressed. The scenario involves a new onset chest pain being evaluated, which goes beyond the scope of a routine AWV. A subsequent AWV, G0439, is reported for the preventive service. Since the physician performed an expanded problem-focused examination and addressed a new problem that required significant medical decision-making distinct from the AWV, an E/M code, 99213 for an established patient, moderate MDM based on history/exam/ordering tests for new problem, is also reported. Modifier 25 must be appended to the E/M code to indicate that it was a significant, separately identifiable service performed on the same day as the AWV. It's crucial to bill both the preventive service and the problem-oriented E/M when distinct work is performed. Question 15. A patient is admitted for acute on chronic systolic heart failure with acute exacerbation. The documentation also states a history of coronary artery disease and atrial fibrillation. The patient is treated with 4 diuretics and titrated medications. What is the correct principal diagnosis? A. I50.23. B. I50.22. C. I50.21. D. I50.20. Answer: A. I50.23. This question tests the specificity of ICD-10-CM coding for heart failure. The key phrase is acute on chronic systolic heart failure with acute exacerbation. This indicates a specific type of heart failure where a chronic condition has acutely worsened. Code I50.23 specifically represents acute on chronic systolic, congestive, heart failure. The other options represent different types or severities of heart failure, e.g., acute, chronic, unspecified. Always select the most specific code that fully describes the documented type and acuity of heart failure. Question 16. A patient undergoes a complex repair of a large ventral hernia, measuring 12 centimeters. During the same operative session, a synthetic mesh is permanently implanted to reinforce the repair. What is the appropriate CPT coding for this procedure? A. 49,561. B. 49,565. C. For 9561, for 9568. D. For 9565, for 9568. Answer: D. For 9565, for 9568. This question tests the correct CPT coding for ventral hernia repair with mesh. The critical information is complex repair of a large ventral hernia, measuring 12 centimeters, and synthetic mesh is permanently implanted. Code 49565 describes the repair of an incisional or ventral hernia greater than 5 centimeters. When mesh is implanted for reinforcement, code 49568 is additionally reported. This is not a bundled service, as the mesh implantation is a distinct component of the repair process, especially for complex repairs. Always remember that mesh placement during a hernia repair is typically a separately reportable service using an add-on code. Question 17. A patient is receiving long-term maintenance chemotherapy for a malignancy. The patient reports to the outpatient oncology clinic for their scheduled intravenous chemotherapy infusion. The nurse administers the chemotherapy over 3 hours. The physician evaluates the patient's response and tolerability, adjusting supportive medications as needed. What CPT codes are appropriate for the chemotherapy administration and physician service? A. 96413, 99213. B. 96416, 99213. C. 96413, 96365. D. 96413, 99214. Answer: B. 96416, 99213. This question assesses the correct CPT coding for chemotherapy administration and associated E/M services. The key details are long-term maintenance chemotherapy, intravenous chemotherapy infusion over 3 hours, and physician evaluates the patient's response and tolerability. For the chemotherapy administration, 96413 covers the first hour, and 96416 is an add-on code for each additional hour, so 96,413 plus 2x 96416, for 3 hours, would be correct for the administration. However, the options given for administration are single codes. Assuming the question intends to capture the most appropriate single code if multiple infusions occur, which is not specified but a common scenario for maintenance, 96,416 represents subsequent hours of chemotherapy, implying that there might be more than one code if the total time exceeds the first hour. Given the options, 96416 represents the typical ongoing infusion. For the physician's service, evaluates patient's response and tolerability, adjusting supportive medications represents a distinct and separately billable E/M service for an established patient, usually a 99,213 or 99,214 depending on the MDM, with adjustment of supportive medications. A 99213 is plausible for moderate MDM. Remember that chemotherapy administration and the physician's separate evaluation and management of the patient are distinct services and are reported separately. Question 18. A 4-year-old child presents to the emergency department after falling from a tree, resulting in a closed fracture of the shaft of the right tibia and fibula. The physician performs a closed reduction with internal fixation using an intramedullary nail. What is the most appropriate CPT code? A. 27759 RT. B. 27756 RT. C. 27750 RT. D. 27762 RT. Answer: A. 27759 RT. This question tests the precise CPT coding for fracture treatment, specifically considering open versus closed reduction and type of fixation. The key elements are closed fracture of the shaft of the right tibia and fibula and closed reduction with internal fixation using an intramedullary nail. Code 27759 describes a closed treatment of a tibial shaft fracture with intramedullary nail, with or without fibular fracture, and with or without internal or external fixation of the fibula. Codes like 27750 are for closed treatment without manipulation, and 27756 is for closed treatment with manipulation, without internal fixation. It's crucial to select the code that accurately reflects both the reduction method, closed, and the specific fixation method, intramedullary nail. Always pay close attention to whether the reduction was open or closed, and what type of fixation, if any, was used. Question 19. A patient is undergoing discharge planning from an acute care hospital. The patient has been diagnosed with aspiration pneumonia and also has a long history of Parkinson's disease, which contributes to dysphagia. The physician documents resolved aspiration pneumonia, stable Parkinson's disease. Which ICD-10-CM code should be sequenced as the principal diagnosis for the inpatient stay? A. J69.0. B. G20. C. Z51.89. D. R13.19. Answer: A. J69.0. This question tests the selection of the principal diagnosis for an inpatient encounter when multiple conditions are present. The key phrase is that the patient was diagnosed with aspiration pneumonia upon admission, and the current status is resolved aspiration pneumonia, stable Parkinson's disease. The principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. Even if resolved by discharge, the aspiration pneumonia, J69.0, was the reason for the acute hospitalization. Parkinson's disease, G20, is a comorbidity. Remember to always select the condition that led to the patient's admission, regardless of their status at discharge. Question 20. A 55-year-old patient undergoes an open radical prostatectomy with bilateral pelvic lymphadenectomy due to prostate cancer. What is the correct ICD-10-PCS code for the principal procedure? A. 0VT00ZZ. B. 0VT00ZZ, 07T20ZZ. C. 0VT00ZZ, 07T60ZZ. D. 0VB00ZZ. Answer: A. 0VT00ZZ. This question assesses the correct ICD-10 PCS coding for an open radical prostatectomy with bilateral pelvic lymphadenectomy. The key elements are open radical prostatectomy and bilateral pelvic lymphadenectomy. In ICD-10 PCS, a radical prostatectomy involves the excision of the entire prostate gland. The code 0VT00ZZ specifically describes excision of prostate gland, total, open approach. According to PCS guidelines, when a lymphadenectomy is performed as an integral part of a radical excisional procedure for malignancy, it is typically considered part of the main procedure and not coded separately, unless explicitly documented as a separate and distinct procedure or if it is a regional lymph node dissection that goes beyond the immediate scope of the prostatectomy. Given the standard description, the lymphadenectomy is integral to the radical prostatectomy for cancer. Always review PCS definitions and guidelines to determine if associated procedures are integral or separately reportable. Question 21. A patient presents to the urgent care clinic with a dog bite to the left forearm, which is bleeding and requires sutures. The wound is 4.5 centimeters in length and is a complex repair due to significant contamination and devitalized tissue requiring extensive debridement beyond simple cleansing. The patient also received a tetanus shot. What is the correct CPT coding for the wound repair? A. 12002-90471. B. 13121-90471. C. 13121. D. 12032-90471. Answer, C. 13121. This question tests the correct CPT coding for wound repair and associated services. The critical information is dog bite to the left forearm, 4.5 centimeters in length, complex repair due to significant contamination and devitalized tissue requiring extensive debridement beyond simple cleansing, and tetanus shot. The complex repair and extensive debridement beyond simple cleansing mean you should use a complex repair code. For the forearm, this falls under forearm, leg, and/or scalp. A 4.5 centimeters complex repair is coded as 13121. The tetanus shot, 90471, is a separate administration service for immunization. However, the question specifically asks for the wound repair, so 13121 is the sole answer for that part. It is important to differentiate between simple, intermediate, and complex repairs based on the documentation of debridement, undermining, and wound closure. Question 22. A patient is admitted to the hospital with acute myocardial infarction, MI. The documentation indicates ST elevation myocardial infarction, STEMI, of the anterior wall. The patient develops cardiogenic shock as a complication during the hospital stay. What is the correct principal diagnosis for this admission? A. I21.01. B. I21.01, or 57.0. C. I21.9. D. Or 57.0, I21.01. Answer, A. I21.01. This question assesses the correct principal diagnosis for an acute myocardial infarction with a complication. The critical information is ST elevation myocardial infarction, STEMI, of the anterior wall and develops cardiogenic shock as a complication. According to ICD-10 coding guidelines for myocardial infarctions, if the patient is admitted due to an acute MI, the MI code is always sequenced as the principal diagnosis, even if complications like cardiogenic shock, or 57.0, develop subsequently during the same admission. The cardiogenic shock would be a secondary diagnosis. Remember that the acute MI itself is the primary reason for admission in such cases, and complications arising during the stay are additional diagnoses. Question 23. A patient undergoes an esophageal manometry procedure. The physician reviews the tracings and dictates a comprehensive report interpreting the findings. What CPT codes should be reported for this service? A. 91010. B. 91010, 91012. C. 91010, 91013. D. 91010-26. Answer: D. 91010-26. This question tests the correct CPT coding for a diagnostic test that includes both a technical and professional component. The key is esophageal manometry procedure, and physician reviews the tracings and dictates a comprehensive report interpreting the findings. Code 91010 represents the total service for esophageal motility studies, manometry. When the physician only performs the interpretation and report, the professional component, and does not perform the technical component, e.g., setting up the equipment, recording the data, modifier 26 is appended to the CPT code. If the physician owned the equipment and performed both, no modifier would be needed. This is a common scenario in diagnostic testing where professional and technical components are billed separately. Question 24. A patient is admitted for pneumonia. The attending physician documents aspiration pneumonia, likely due to recent stroke with dysphagia. The patient is also known to have chronic kidney disease stage 3. What is the correct sequencing for the principal diagnosis? A. J69.0. B. I69.390. C. N18.3. D. J69.0, I69.390, N18.3. Answer: A. J69.0. This question tests the selection of the principal diagnosis when a clear reason for admission is stated with an underlying cause. The critical information is admitted for pneumonia and the documentation aspiration pneumonia, likely due to recent stroke with dysphagia. The aspiration pneumonia, J69.0, is the condition chiefly responsible for the inpatient admission. While the stroke, I69.390, and dysphagia are the underlying causes and important comorbidities, they are not the reason for the acute admission. The chronic kidney disease, N18.3, is also a comorbidity. Remember, the principal diagnosis is the condition that occasioned the patient's admission to the hospital, even if it's a complication of a chronic condition. Question 25. A patient presents with a displaced fracture of the distal radius, Cole's fracture, of the left arm. The orthopedic surgeon performs a closed reduction of the fracture with percutaneous fixation, K-wires. What is the appropriate CPT code for this procedure? A. 25605 LT. B. 25606 LT. C. 25607 LT. D. 25608 LT. Answer: C. 25607 LT. This question assesses the specific CPT coding for a distal radial fracture treatment. The key elements are displaced fracture of the distal radius, Cole's fracture, and closed reduction with percutaneous fixation, K-wires. Code 25607 describes a closed treatment of a distal radial fracture with manipulation and percutaneous fixation. Code 25605 is for closed treatment without manipulation, and 25606 is for closed treatment with manipulation but without percutaneous fixation. The inclusion of percutaneous fixation is the key detail differentiating 25607 from other options. Always pay careful attention to the type of reduction, open or closed, and the specific fixation method, internal, external, or percutaneous, used to ensure accurate CPT coding for fractures.